Good afternoon, class. Told a couple of students that I was going to try to just do a quick review video for y'all and post it to Canvas. Haven't done this before, so we'll see how it turns out. So on the unit that you guys have a test on Monday, cardiovascular, just a little bit of urological, and then immunological. Okay, so let's I'm going to start with the urological. I should have had it marked. Let's see, 16, 20. Okay, that's chapter 20. The few things that I wanted you to know from this unit, of course, mentioned the contraceptive management on page 391. When women 35 or older than 35, I should say, the text says women older than 35 have to be very cautious about taking hormonal contraceptives. That's the second paragraph, because they put the woman at increased risk for serious side effects such as formation of blood clots. So this can be it's kind of dangerous for any woman, or the risk exists for any woman, but especially for a woman that's over 35, and then that risk goes up if she smokes. So if she's over 35, she smokes, she's at increased risk for blood clots. And then so what that says is that, let's just say if a woman has a history of blood clots, then she's just really not a candidate for hormonal types of contraceptives. Or if she's had a stroke, which may sound crazy. You may think, oh, she's 35, of course she hasn't had a stroke. But people do have strokes very young. So women with a history of blood clots or diseases involving the vascular system should not be prescribed these medications. So as part of teaching, you want to educate your female patient if she is prescribed a hormonal contraceptive. That's going to be like your birth control pills, the Depo shot, some like the NuvaRing and such. You want to educate them that they do not need to smoke. And if they're unwilling to stop smoking, or if they are unwilling to not smoke, then the doctor may need to get them something different. If you look on page 394, 395, here we're talking about the men with erectile dysfunction. Remember, I asked you guys the question. I said, why do y'all have sex? And somebody said for pleasure, and somebody said it feels good. Well, to say that it feels good really hits the nail on the head, in that it makes it easier for you to remember some of your medicines for erectile dysfunction. Now, it's important that you understand these medicines, they don't really play a role in helping a man be more fertile per se. They just help him to be able to acquire an erection and maintain the erection. And remember, we said, just for anybody who don't remember, during sexual arousal, the penis is supposed to be hard and erect. Okay, instead of like this, like usual, it's supposed to be like this and stay like this for a period of time. Well, people with erectile dysfunction, they're either unable to acquire an erection or unable to maintain an erection. Most of us have heard of Viagra. Maybe some have heard of Cialis, but we said sex feels good. So the generic for Viagra is sildenafil. Sildenafil. We do it looking for a feeling, okay? Generic for, let's just say, Levitra or Cialis is vardenafil, okay? So I want you for sure to know Viagra and its generic sildenafil, but I also want you to know that if you happen to see one that you're like, I haven't heard of that, if you see a fil on the end, it's probably an erectile dysfunction medicine, okay? And these are usually taken, some of them, you don't have to know this, some of them are taken like 30 minutes before anticipated sexual intercourse. I think there's one they've got now that you can take every day. But what I do want you to know about this is the mechanism of action. Okay, so arteries, our arteries in our body are responsible for taking blood supply from the heart and going out to the rest of the body. Okay, and then the veins in our body are responsible for taking that blood back up to the heart. Okay, so the reason why these medicines work is they dilate the vessel and enable blood supply to get into the penis. But we don't need it to just get there, we need it to stay there, okay, for a certain length of time. So these medicines will cause the vein to constrict so that the blood cannot leave the penis for a certain period of time, but rather stay there, because it is the blood flow to the penis that causes and maintains the erection. Okay, we don't need to allow men who are on these medicines to take nitrates. Remember, we said nitrates cause vasodilation. So anytime we have vasodilation and then we have two medicines that can cause vasodilation, we can have unsafe drop in blood pressure. Okay. We say diuretics for the cardiac unit. I meant to go over with y'all on medicine for like men who have enlarged prostate, but I think I will just cap that on with our next unit. I'm not going to put any more on y'all for this unit. Okay. Let's see. Let me make sure that I've not forgotten anything for this unit for urology. Okay, so if you will go to 16, let's go to chapter 16. That's the cardiovascular system medications. All right, so this starts on page 294. Okay. So we said that the cardiovascular system plays two roles in the body. One is to deliver much needed nutrients such as oxygen, hormones, immune, and clotting factors to every part of the body, including the heart. And then the other role is to carry waste products such as carbon dioxide out of the cells. All right. So we talked about what myocardial infarction is. That is what's commonly known as a heart attack. And what that is, you have a certain area of the heart that has been deprived of oxygenated blood flow. Okay, so you may have a vessel leading to the heart that is narrowed, or that is clotted off, or has plaque buildup, whatever the case may be, and it is not allowing the heart, that part of the heart, to receive oxygenated blood supply. So chest pain can be a symptom of myocardial infarction. So chest pain can be a symptom of a total lack of oxygen called anoxia. So anoxia means there's a complete lack of oxygenated blood supply. And then hypoxia, of course, means it's not a complete lack, but we don't have sufficient blood supply, okay, to the heart muscle. And then ischemia means tissue death, tissue injury or death. So you can have somebody that has a heart attack, and typically it means that a certain part of the heart, that heart cells or the muscle has had significant injury or death. Okay. And then cyanosis, if you've ever seen anybody with like blue lips, maybe fingers are discolored, and maybe their oxygen level may be 82, then those people are cyanotic. Okay, the cyanosis is the discoloring. The fact that their oxygen level is low, they are hypoxic. They have a low level of oxygen, but they have some. Okay. All right, so a CVA, that's a stroke. That just means a certain area of the brain has been deprived of oxygen, and blood flow for several minutes. And just to kind of recap, we talked about there are two types of strokes. Hemorrhagic, meaning we've had a bleed on the brain, and then ischemic, meaning the brain has been deprived of blood flow, usually due to narrowing of a vessel or maybe some type of clot or plaque buildup or something like that. All right. So let's start on page 296 with our cardiovascular medicines. So that's just an overview. Actually, let's start on 297 actually. Under anti-anginal medicines. So angina pectoris, that is the chest pain. Now it's not a chest pain, it's not the same as if somebody's pulled a muscle in their chest, okay? Chest pain is what Miss Wilson says, the heart, angina is the heart going, help me, help me, help me, okay? I hope she doesn't mind if I borrow that. It's chest pain caused by a lack of oxygen and nutrients to the heart muscle, okay? So we may give someone an anti-anginal medicine, which means that not only is it gonna just help with the chest pain, but it helps with the chest pain because it dilates the heart, the vessels, not the heart, but it dilates the vessel, okay? Dilates the arteries and veins. An example of this is your nitroglycerin, or you may call it nitrostat. There are several different brand names, but the nitroglycerin, okay? That's the one we talked about. If somebody's having chest pain that we anticipate is cardiac related, we're going to give them most likely a sublingual form of the nitroglycerin. We're going to put a tablet under their tongue. Okay, we can give them 5 minutes, see if that's better. If it's not, we can give them another. Give them 5 minutes, see if it's better. We can give them another. We can do that 3 times max, okay? So if somebody's in the home setting or if they're in a nursing home, we can do that 3 times. But if after that 3rd time it's still hurting, it hasn't let up, we need to be getting them to the ER, okay? Or if they're in a hospital setting already, like for instance, if they're on the floor, you know, there are other steps and measures, but we're gonna have to take that level of care up to the next level, okay? And then, you know, you got the nitroglycerin patches, the creams, etc., but the most common is gonna be your sublingual. It can be also given IV. Now, sometimes chest pain is musculoskeletal related. You know, you may have pulled a muscle in your chest or something, but we can't take it for granted that, oh, it's probably just a pull muscle. We have to make sure that we rule out cardiac problem. And if it is musculoskeletal, we'll do probably do NSAIDs, okay? And if you don't know what NSAIDs are, just be sure you go back to the material from the previous unit to review that, okay? Be sure to review your little box at the bottom of 297. All right, on 298, we're talking about anticoagulants, antiplatelets, and thrombolytic medicines. So there are different reasons why we may have somebody on an anticoagulant. What is an anticoagulant? It is a medicine that hinders the body's mechanism to clot, okay? And it's usually because sometimes a person may have a clotting disorder where they, you know, may have had a DVT in the past, whether it's for, you know, from just inactivity, or some people have a clotting disorder. All right, so anticoagulants such as warfarin, that's the generic for Coumadin. All right, so also we talked about heparin. All right, and enoxaparin, that's generic for Lovenox. Now heparin, it's just heparin, okay? You don't have to try to remember what a brand name is. And then enoxaparin is Lovenox, okay? So warfarin is going to be a tablet by mouth. That's the only form that it is available in. And then Lovenox, the enoxaparin, is always going to be given sub-Q and is always going to be in the abdomen. Now, I may have given one in the arm one time because the patient was absolutely blatantly refusing to receive it in the abdomen, and the doctor said it was okay, but you just always need to remember that Lovenox is going to be given in the abdomen, and it's given to prevent blood from clotting by interrupting the production of proteins So vitamin K controls creation of factors. So basically, we talked about vitamin K. I think it was in maybe one of our our earlier lectures. It helps our blood to clot. Well, sometimes we need that vitamin K to just, hey, settle down a little bit. You know, we don't need all that clotting going on, okay? So we may give them an anticoagulant. So as I said, cumin is given orally. And the lab, so cumin is one of those medicines that we talked about that, like, medicines have a narrow therapeutic index. Too much, not enough is dangerous, too much is dangerous, okay? So we have to monitor a person's PT/PT-INR, okay? We have to monitor PT-INR to make sure that they're thin enough but not too thin, okay? And typically the goal is going to be between 2 and 3, but depending on why a patient is taking Coumadin, that's the doctor is going to, or the pharmacist is going to decide how thin they need to be, okay? But just kind of on an average 2 to 3 for the INR, but I'm not really requiring that you guys know that because everybody's not the same. Like if a person's got a history of clots in the lung, a lot of times they'll want them to be thinner than if somebody's just had a clot in the leg. Then Lovenox, which is enoxaparin. So we don't really check labs with that. We definitely do a CBC. You know, we want to look at the hemoglobin and hematocrit. We want to look at platelets because if somebody's already got low blood, we don't want to be thinning them out. But there's not a special lab that we check to monitor their coagulation per se. And so just so you know that Lovenox or enoxaparin, it is a low molecular form of heparin. So as I said, it's always given sub-Q, and when you give it, you know, with most sub-Q injections, you will pinch. Well, with any blood thinner, whether it's heparin sub-Q or enoxaparin sub-Q, you're not going to pinch because it's already going to make them bruise because it is a blood thinner. So if you pinch when you administer, you're just going to increase, you know, bruising. And anybody that's getting Lovenox or heparin injections in your belly, you can definitely tell it because they have big bruises, okay? And then of course, so we can give these, the enoxaparin and the heparin, we can give it to treat an existing blood clot, or we can give it to prevent blood clot. So a lot of times, you know, when you go to clinical at Baptist or any hospital, you'll notice a lot of times they'll be on enoxaparin. Usually heparin is going to be given if somebody already has a blood clot, and then the same with warfarin. I've never seen it be given prophylactically or preventatively. So you do need to know what the antidote is for Coumadin or warfarin. What is the antidote? Vitamin K, all right? Heparin, the lab that we monitor is the PTT. You can remember however you want to, but remember I said HEP, H-E-P, PTT, HEP, patient to thrive. Help the patient to thrive, okay? And then the antidote for that is protamine sulfate. I remember y'all already knew that in class. So anytime a patient is on any blood thinner, we need to discuss bleeding precautions, risks. I told you to make that box at the bottom of 298 your best friend. I still say that, okay? And I gave the example in class. Let's just say if you send a little man home that's going to be on either of these blood thinners or any other, maybe Eliquis or Xarelto, you know, some of the newer ones. We don't want them on a ladder trimming branches. We don't want them on a ladder fixing the cleaning out the gutters, all right? We don't want, even if it's a woman, anybody, we don't want them on ATVs or motorcycles. Now, all you can do is educate. What they do outside of your presence is their business, but you got to educate them that just the slightest fall or bump to the head can result in a brain bleed, which could totally mess them up, okay? When they're shaving, they need to use an electric razor, okay? If they cut themselves, just let them know, you know, you're probably going to bleed more than the average person. Somebody's on a blood thinner or an anticoagulant, we don't want them eating loads and loads of collard greens and any other green leafy vegetables or any other vitamin K foods, rich foods that's mentioned here, okay? They need to monitor for and report bleeding in their stool, in their urine, and any other precautions that it gives. Just let them know they need a very soft toothbrush. So be sure you read over that. So if a person is on a blood thinner and they're going to have surgery, usually the doctor's going to give orders for when he wants them to stop the blood thinner prior to surgery, okay? And then a lot of times after a patient has had surgery, they may be on a blood thinner because they're not up and about as much. And then, of course, if somebody has a DVT in their leg, which is a blood clot in their leg, just know that they have an increased risk for having a blood clot in their lung. And what happened is the blood clot can travel from their leg to the lung, or just a piece of it breaks off and can go to their lung, which can be deadly, okay? And of course, with that, they'll have shortness of breath and sharp pain in their chest, coughing, etc. Let's see. So those are what we call anticoagulants. So this next is antiplatelet. So that's going to be like your aspirin, and the two I told you I wanted you to know for sure: aspirin and clopidogrel or Plavix. All right. So they keep the platelets from congregating. Now, platelets are real good friends. Okay. They love to all get together. Okay. They are with one accord. So if you cut your finger, they're going to all rush to your aid, and they're going to cause your blood to clot at that site, okay, so that you stop bleeding. All right, so if you got somebody that is clotting too much, or let's just say if they've had stents or something placed in vessels, we don't want all that clotting going on, okay? We don't want all that congregating going on, so they'll be on aspirin or clopidogrel. And the same precautions, bleeding precautions, maybe not to the exact same degree, but we're still going to implement the same precautions, okay? So just remember, aspirin is not only for pain, it's not only for fever, all right, but it's considered an antiplatelet, all right? So be sure to read all of that and go over that again. And then on 299, patients taking antiplatelet medicine should also learn the signs of bleeding. Same with the, and also they don't need to be consuming high doses of vitamin K. Same for them, okay? And then at the bottom of 299, we talk about the thrombolytic medications. So if other medications fail to prevent blood clot from forming blood vessels, thrombolytics can dissolve them. Basically, what I want you to know is that a clot in a vessel is a DVT, or the same as a thrombus. And as I just said, it can break loose and result in embolus, which is in the lung, okay? The thrombolytic medicine, that's a higher level of care, but just know that a lot of times they'll give that, and that's usually going to be in a critical care setting. On 300, we talk about stroke. So, with a stroke, one of the most important things to know is, when did symptoms start? We call it, in the healthcare setting, when was their last known well time? So, let's just say you've got a loved one that all of a sudden they get to where they can't talk, they're out on the left side, they can't move it, and you take them to the ER. Like, the first question they're going to ask is, when was their last known well time, or when did this start? And the reason why that's so important is that if they can get treatment within 60 minutes of the onset, then if the stroke is an ischemic stroke, which means it's due to some type of, it's anything other than a bleed, okay? If it's a stroke and it's not due to a bleed, then if they can get treatment no more than 60 minutes after the symptoms started, then your outcomes are better. You can probably have reversal of their deficits. So maybe they were out on the left side, they couldn't talk. Well, if they can give this TPA that we talked about, then our outcomes are better. but you have to give it within 60 minutes of it. And if a patient has just been found down and you don't know how long it's been, then they're usually not a candidate for the TPA. So be sure you read and review that paragraph. Go to, all right, medications for hypertension or high blood pressure. Look at page 302. Okay, so we have our ACE inhibitors, all right? So we said ACE inhibitors block the renin-angiotensin pathway from the kidneys to decrease blood pressure. They also help reduce the possibility of heart failure by blocking the action of renin-angiotensin system. So with these, we said these are the Pril sisters, okay? The two examples that I gave you, I think I gave you the benazepril, and I know I gave you the lisinopril. If you don't freak out, if you happen to see a captopril, lisinopril, if you see a Pril, just know it's a really good chance that it is an ACE inhibitor, okay? So any medicine that we are giving to try to lower blood pressure, just know one of the potential side effects is going to be an overcorrection of your problem, which would be hypotension, okay? So with this, particularly with the lisinopril, but with your ACEs, you can have a cough. Remember, we talked about the angioedema, where we have the dangerous swelling of the throat, the lips, the tongue, okay? So there goes our patient education again. Got somebody that's on lisinopril or one of the Prils, we want to tell them, now, if you happen to notice your lips seem like they're starting to swell, your tongue or whatever, you need to stop and immediately get to the ER, okay? Remember, I told you about that patient I had in the ER that was on a ventilator just due to the severe angioedema. We got to watch these people's potassium because it can tend to go up. You have to know your levels, okay? We are going to have levels, you're going to have lab levels from here on out, so you really need to go on and learn them, okay? Your angiotensin, your ARBs, okay? Another class of medicines that's given for hypertension. A lot of times they'll put people on this if they don't tolerate the ACEs, or it may just be that the physician prefers the ARBs, okay? These are the TANs, all right? The TAN clan. So we got the losartan and the olmesartan. I think I just kind of honed in on those two, but if you happen to ever see telmisartan, valsartan, if you see a sartan, you better know it's probably an ARB, okay? And with that, we're just going to monitor blood pressure to make sure that it's not getting too low, all right? Then we talked about our beta blockers, okay? You will most likely hear them referred to as beta blockers, but that's kind of like short for beta adrenergic blockers, okay? Remember, they relax the fight or flight response of our body. They are the ones that tell us, hey, chill out, okay? So when we chill out, our blood pressure can tend to go down, all right? So with our beta blockers, they act on the alpha and the beta adrenergic receptors. Our examples are our metoprolol, right? The brand for metoprolol is Toprol, Toprol. And so I think I told you the metoprolol and the atenolol, the propranolol, okay? If you see OLOL at the end of a medicine, even if you have never heard of this one before, but if you see OLOL, you better bet your dollar that it's probably a beta blocker, okay? So you need to know the classes of medicines, but they're constantly coming out with new medicines. Nobody can keep up with all of them. But if we can know, like if we are like, oh, I never heard of this medicine before, if we look it up and we say, and it says, oh, it's a beta blocker, then you just need to know, oh, it goes in the class with the metoprolol, it just goes in the class with the propranolol or the atenolol, okay? So we said with the beta blockers, not only will they lower blood pressure, but they will definitely lower heart rate, all right? So anytime we're going to give a beta blocker, or we think we're going to, what do we got to check? Not only the blood pressure, but heart rate. So we are going to auscultate, listen to an apical pulse for 1 minute, all right? If it's lower than 60, we're gonna hold that medicine and either talk to the RN or talk to the doctor. Now, you may get in a medical facility and your doctor may have other parameters. They may say, hold if less than 55, that's fine, but for school, you know, for text, we're just gonna learn less than 60. So it can cause bradycardia, and they have to be used very, very cautiously with diabetics and patients with asthma, because they can cause bronchospasms, and with diabetics they can mask the symptoms of hypoglycemia. So a person could be having a hypoglycemic episode, meaning their sugar is low, but the beta blocker is already telling you to chill, you know, so it can mask those symptoms. But it does manage hypertension, and also can manage, beta blockers can also be given to manage angina. And if you'll see there, it can slow the heart rate. Sometimes you may have somebody that's, for whatever reason, having trouble with their heart beating too fast, such as with Graves' disease, like your thyroid is overactive. You know, they'll put them on a beta blocker to slow that heart rate down, okay? So the next class of medicine that can be given for blood pressure, for hypertension, is your diuretics, all right? This is what you hear people refer to as the fluid pills. So you have your thiazides, that's like your hydrochlorothiazide. We call it HCTZ, okay? It's not gonna spare potassium, okay? It's gonna take a little bit with it. So not only does the hydrochlorothiazide pull fluid off, but as it pulls fluid off, as I said, it's gonna take a little potassium with it. So we might tell a patient, increase your potassium intake, okay? They may or may not put them on a potassium supplement with this one, but they may tell them to increase their potassium intake. Potassium sparing diuretic. So that's going to be like your spironolactone. Now, this medicine, when you take the spironolactone, which the brand is aldactone, it's going to pull the fluid off, but it's not going to take the potassium with it, okay? So which means you can develop a higher concentration of potassium in your blood, all right? So which means you can end up with hyperkalemia. Again, know your lab levels. So with these, we've got to closely monitor our patient's potassium level because it can get too high. Now, salt substitutes. I'm not sure if I thoroughly explained this in class, but we want to tell these people to avoid salt substitutes. That's because salt substitutes, like let's just say a patient doesn't need to consume a lot of sodium. And so you can get these seasonings that are salt substitutes. They have good flavor. Well, they have a lot of potassium in them. So if we're worried about a patient's potassium being high, then we do not want them to be on salt substitutes. So before you give spironolactone or any potassium sparing diuretic, what should you be checking? You better look in the labs and see what that potassium level is. That potassium level is 6.2. Are you going to give it? I don't think so. I hope not. You're going to hold it and get further orders. Loop diuretics. They are the most potent of the 3 diuretic classes. That's going to be like your furosemide, torsemide, bumetanide, okay? Let's see. The amide, torsemide, I think the ones I told you were the bumetanide and the furosemide, okay? Those are pretty common. So they are not potassium sparing. When they take the fluid, they're taking potassium with it, all right? So you can really get some serious hypokalemia with these diuretics, okay? Meaning we can really get some low potassium levels. So if you're fixing up your medicines to go down the hall to give a patient their meds, before you even think about giving them one of these diuretics, you better know what that potassium is. And then, so if I have a test question that says a person's potassium level is 2.8 and you're about to give them furosemide, what would you do? You're not going to proceed with giving it. You're going to get further orders, okay? So a lot of times with these medicines, with, you know, your furosemide, your bumetanide, a lot of times they're going to put them on a potassium supplement. Let's see. And of course, I think it was one of the couple of chapters ago, we talked about, with low potassium, people can have muscle weakness, muscle cramps. Okay. Then we talked about our calcium channel blockers. That's also another class of medicine given for hypertension. Calcium channel blockers are used to treat angina also. That's like our amlodipine, which is generic for Norvasc. That's like our diltiazem, generic for cardiazem. Okay. So we've talked about all these different ways to decrease, or all these different medicines to decrease blood pressure. But the last paragraph on 303, not the last paragraph, the last paragraph before medicines for heart failure, medications or methods to decrease or regulate blood pressure without medicine include weight loss, stop smoking, decrease sodium intake, limiting alcohol, reducing stress, and exercise. Okay, and always if we can, control blood pressure with those ways, it's always better, but a lot of times that's just not the case. So medicines for heart failure. All right, so the medicines that we just talked about, we use those same medicines for heart failure to treat the symptoms. Our ACEs, our ARBs, our beta blockers, our diuretics, okay? They all are going to help treat the symptoms of heart failure. Remember, with heart failure, a lot of times patients will have a lot of swelling. They may have shortness of breath. The heart is it's just not pumping strong, okay? It's pumping, but it's weak, all right? So, let's see. So the last paragraph from 303, in addition to taking medicines, patients can decrease their symptoms and risk for complications by stopping smoking, exercise, lose weight, decrease, same thing, okay? Same thing to decrease, to control the blood pressure. So uncontrolled hypertension over a period of time is one of the things that causes heart failure, okay? And just know, nicotine is a vasoconstrictor. We want our vessels to be nice and patent, okay? So the blood can just flow freely. But when we do the nicotine, it's a vasoconstrictor. So it makes those vessels tight. So the blood has to really work hard. The pressure inside the vessels are high because that blood supply is trying to get through there, okay? I think we just kind of touched on vasodilators. But cardiac glycoside, and then the one we talked about is our digoxin, okay? That's generic for lenoxin. So the cardiac glycosides increase the strength of the heart contractions. So what they do is, our blood pressure medicines, they're gonna decrease the resistance in the vessels. Well, the cardiac glycosides is gonna work on the heart muscle itself. Instead of the heart beating like this, it's going to help it beat more efficiently, stronger. It is like it'll have the heart slow down and beat stronger, okay? So, the things to remember with that. The antidote is Digibind, okay? So, we're going to monitor for dig toxicity. I told you the bottom of page 304. I told you to make that box your best friend, okay? The symptoms of dig toxicity, we get nausea, vomiting, diarrhea, abdominal pain, slow heart rate, greenish halo around lights are signs of toxicity. We want a person's dig level. That's another medicine that has a low therapeutic index, okay? We don't want it getting too high. With dig, we want that level to be less than 2, okay? The range is like 0.5 to 2, but I'm just going to tell you to remember less than 2, okay? Now, with dig, if you hear me say dig, okay, we say that short for digoxin, you have to monitor that potassium level. So before you administer digoxin to a patient, you better be checking that potassium level. Look on the chart and check it, okay? Because, as we mentioned in class, potassium level being low can increase risk for dig toxicity. And then also, before we give it, we got to listen, auscultate, for a apical pulse for 60 minutes. I'm sorry, for a minute, okay? If it's less than 60, we're going to hold and get further orders, okay? And then the best way, if you look at the little box on top of page 305, the best way to make sure that you don't miss a dysrhythmia or like an abnormal rhythm, heart rhythm. Remember we talked about the heart's supposed to keep that same rhythm, but when it veers from that, then it's abnormal. The best way to not miss out on that is to auscultate for a minute. Now, yes, it is okay to, you know, get a radial pulse, but if you got a patient with any type of history, you need to listen. On our diuretics, just kind of going back, we got to be sure that we're getting daily weights. Be careful with your weighing. People are lazy. They will have 50 covers on the bed, and a staff member will literally just weigh them, and then they've gained 30 pounds in one day. Not okay. Don't be lazy. Take all the covers off the bed. You know, they can keep the fitted sheet, they can keep the top sheet, they can keep like one pillow, but beyond that, no, take it off. And do that consistently around, and you know, patients at home need to weigh around the same time every day, okay, with about the same amount of clothes on. A good rule of thumb is weigh first thing in the morning before you eat or drink anything, after you've peed, in your pajamas, okay? So, all right, we talked about very briefly dysrhythmias. That's dysrhythmia and arrhythmia are the same. That just means an abnormal heart rhythm, okay? And we mentioned amiodarone is one of those medicines that we give for abnormal rhythm. Beta blockers, they can give calcium channel blockers. All of those can be given for dysrhythmias, okay? And we mentioned that amiodarone is actually a potassium channel blocker on page 305. And with calcium channel blocker, we discussed that in the past, but here are some more examples of some calcium channel blockers. With shock, you'll learn about that. There's cardiogenic shock, but you will learn about that in med-surg or alterations. And of course, we've gone over anaphylactic shock. You know, that's where we have the wheezing, the trouble breathing, you know, the swelling of our airway. That's usually due to an allergic reaction to something, okay? Medicines for lipid control on the bottom of 306. So this is like for patients who have high cholesterol. So we need to know that LDL is our bad cholesterol and HDL is our good cholesterol. So our cholesterol medicines, a lot of times the intent is to raise the good, lower the bad, okay? So our statins, if you look at, the last paragraph on 306, our statins. So what they do is they decrease the blood level of lipids. These drugs encourage the liver to make less cholesterol and increase the number of LDL receptors in the liver. So what I want you to remember is some examples of cholesterol medicine. If you see, okay, atorvastatin, pravastatin, those are just two examples. But if you see a drug and it ends in statin, I need you to know that that's most likely a cholesterol medicine, all right? So, talk about precautions with that. We have to monitor liver enzymes very closely, all right? Because they can damage the liver. So, what can statins damage? What can statins cause? Liver and muscle damage. So, how will you know that it's bothering somebody's liver? You guessed it. You better know those liver enzymes. Your AST, ALT, or you may wish to refer to it as SGOT, SGPT. I usually put both on the test so that you'll know that you'll recognize either of them. So you're going to educate your patient that if they are on a statin, they do not need to be drinking, okay? They might do it anyway, but you educate them not to, all right? So, and then you need to tell them also, and tell them why, all right? So also you need to explain to them that if they start having muscle pain or weakness, joint pain or weakness that they normally don't experience, they need to stop that medicine and call the doctor, because you can end up with some muscle damage. And I kind of explained it in class, called rhabdomyolysis. That's something that's pretty bad. It ends up damaging your muscles and end up with renal failure. So just remember, with your cholesterol medicines, your statins can cause liver and muscle damage. All right. So, and then another medicine that we have to take cautiously is acetaminophen. It's just that anything that can cause liver damage, you don't want to take a little bit of this that can cause liver damage. You already take a little bit of this. All these things combined, okay, and then you just get more than the liver can handle. All right. So if somebody is already in liver failure, they're usually not going to be on a statin. Okay. Read the box bottom of page 306. Those are just some ways that we can help lower our cholesterol without taking a statin. Okay. So the medicines that I have mentioned to you in this video are the medicines from this unit that you need to know. You need to be able to, if you see the brand, you need to know what the generic is. If you see a generic, you need to know what the brand is. All right. So page 17, 319, our immunological medicines. We talked about what autoimmune disorders are. We talked about what antihistamines are. I'm not going to go back over that. Just, you can read and review that yourself. What I'm going to go over now, I'm not going to go back either over the NSAIDs. You need to review those, okay? Remember that your ketorolac, your ibuprofen, naproxen, you need to know that those are NSAIDs. Several of you missed on the test. Our last test indicated that Tylenol has an anti-inflammatory effect. It does not, okay? It does not suppress inflammation. It does not help reduce inflammation. It is not good for inflammation. It's not going to be given for inflammation, okay? It will help with pain, yes, but it will not have an anti-inflammatory effect. Let's see. All right, let's talk about antibiotics on 321. So antibiotics treat only bacterial infections. They do not treat viral infections. They do not treat fungal infections, okay? They don't treat yeast infections, okay? They just work on bacteria, okay? So this is something that I want you to make sure that you understand. If a patient, let's just say a patient comes into the hospital and they've got a big wound on their foot, and the doctor says you need to start them on this antibiotic and get a culture. Or if they come into the hospital and the doctor says they got a UTI, I know they do, start them on this antibiotic and get a UA. Before you start the antibiotic, regardless what it's for, you always get your specimen first. So if the doctor says culture this wound, you culture it before you start them on the antibiotic. So don't okay, I'm gonna go ahead and hang this antibiotic while I go get the stuff to do the culture. Don't be like, I'm gonna go ahead and hang this antibiotic, and she can't pee right now, but in a little bit when she can pee, we'll let her pee. No, get your specimen first, then start the antibiotic. Otherwise, your results can be skewed, okay? I want you to read 322, that paragraph in the middle. I think I told you in class about superinfection. Review that. So, on 323, under penicillins, all right? So penicillin's been around for a long time. I think this is one of those. I said penicillin, and it'll probably be around when Jesus comes. That's an example is like amoxicillin, and thus the name penicillin, okay? These medicines are given orally, topically, and via injection, and they can treat infections such as like strep throat, otitis media, which is ear infection, okay? Unfortunately, a lot of people are allergic to penicillins, okay? And so more expensive antibiotics are prescribed for them, such as the cephalosporins, okay? They're similar to penicillins, but typically a lot, patients that can't take penicillin, they can take cephalosporins. They're just more expensive, all right? Let's see. Ceftriaxone is a good example, like Rocephin. If you ever work in a doctor's office, you will give so much Rocephin, all right? Cefepime is another one, but Rocephin is the one I gave you in class to remember, okay? And so they're good for certain streptococci infections. Let's see. This group of medicine is used to both treat and prevent infections. The use of alcohol should be highly discouraged, okay? So with these, we don't want, they can definitely mess your stomach up if you consume alcohol on this medicine. So go back and review that paragraph. Review the box at the page, at the bottom, at the top of 324 about drug-resistant bacteria. We talked about that in class, about how we end up getting drug resistant. Okay, that's very important. You need to review that box. Okay, now we have our tetracyclines. Okay, tetracyclines are commonly, they're very old. All right, examples are the name tetracycline and doxycycline, and it's used to treat like gonorrhea, chlamydia, UTIs. All right, these medicines should never be prescribed to children or pregnant women because they cause permanent staining of the teeth. And then we also just talked about you can get sunburn really easy. I know that doxycycline for sure. You will get sunburn really easy. They need to be on SPF 30 or higher if they're going to be on one of those, and they really don't need to be out in the sun if at all possible while they're on that. We talked about antibiotics in general. If you don't want to be pregnant, then you need to take other precautions, because if you're on an antibiotic, it can decrease the effectiveness, or it can alleviate the effectiveness of your contraceptive. Our macrolides, we said example of that is azithromycin. Used to be back in the day, everybody got a Z-Pack. If you went to the doctor and had sinus symptoms, everybody got a Z-Pack. They've backed off of that some, because a lot of times these infections are viral anyway. But they're often used to treat upper and lower respiratory infections, skin infections, pelvic inflammatory disease, sinus infections, I think I said that, bronchitis, pneumonia, ear infections. Okay, and then our aminoglycosides. So our aminoglycosides are very stout. They mean business, okay? So example of this is going to be like your gentamicin, your iacins, okay? These are some that another class of medicine that have a narrow therapeutic effect, okay? They gotta have the right amount in your system for it to work, but too much is gonna, have toxic effects. And they're, like I said, they're more toxic than other antibiotics. Patients taking aminoglycosides systemically should have blood levels of the antibiotic monitored periodically for efficacy and toxicity. So this is another one of the medicines that, like in the hospital, somebody is on like IV gentamicin, they're going to end up getting blood levels of that medicine checked. Maybe the doctor, based on the lab level, the doctor may have to increase the dose, or he might have to decrease the dose, okay? And they are used only when no other suitable anti-infective is available, because the risk for damage to the patient's hearing and kidney function. So what are those two words? So aminoglycosides can cause ototoxicity and nephrotoxicity. How will we know that somebody is potentially getting nephrotoxicity? We're going to look at the BUN and creatinine. How will you know? You ain't going to know unless you know your lab levels, okay? Commit those to memory. What are some symptoms of ototoxicity? That could be decreased hearing. It could be tinnitus or tinnitus, which is ringing in the ears. Poor balance, because we know our ears help control our balance, okay? So if I ask you what labs will be checked closely for a patient that's taking an aminoglycoside, well, the lab will check, they'll have the lab check the medicine level, the gentamicin level or whatever the antibiotic is, and they'll check the BUN creatinine. Our quinolones, that's going to be like our ciprofloxacin, okay? And oxafloxacin. They're considered broad spectrum antibiotic because they are effective against a wide variety of microorganisms. So most antibiotics are just like, they're used to treat certain bacteria, because certain bacteria are let's see, how can I say that? Certain bacteria is will buckle with certain antibiotics, okay? So all antibiotics won't work for every bacteria, okay? But when you get antibiotic that's broad spectrum, then it's not going to treat just a couple of different kinds of bacteria. It's going to treat a broad spectrum of bacteria, okay? And that's the case with our quinolones. So with that's like I said, with ciprofloxacin, it can cause a ruptured tendon. We usually refer to like the Achilles tendon, but it can cause ruptured tendon, which I think it's pretty amazing that an antibiotic can cause that. Let's see. So our sulfonamides, all right? So sulfasalazine. If you see sulfa at the beginning of a medicine, it's probably a sulfa derivative. And patients who are allergic to sulfa do not need to be on this, okay? So, because these sulfa drugs tend to collect in the bladder before they are excreted, they are very effective in treating urinary tract infections. So that's why for many years, a lot of patients are put on Cipro, because Cipro is one of those things that it'll just kind of collect and sit in the bladder longer, and then, you know, that just helps get rid of the bacteria. And as I said, many patients are allergic to sulfa drugs, and if they are, they can have a severe skin reaction called Stevens-Johnson syndrome. And I hope you look that up to see what that looks like I told you in class. It's pretty amazing to see. All right, the bottom of page 325, our antifungal medications. So we've gone over some already before this unit, but our nystatin, our miconazole, you're in the field, you're going to be, you know, applying miconazole powder. Remember I told you about our little old ladies that have the sagging boobs, and you know, you got to lift them up, well, in the abdominal folds and such. Well, you're going to end up applying a good bit of miconazole powder, sometimes Desonex, just, you know, statin, nystatin, that's another antifungal, okay? So just be sure that you know the nystatin, and I think I may have told you in class the miconazole, but we've already talked about the nystatin. Let's see. And on 326, we just went over acyclovir. That's typically going to be given for a viral infection such as like shingles, or you know, people have fever blisters. It's not gonna, all it does is it helps shorten the duration of the symptoms, help decrease the severity of the symptoms. But as we know, with viral infections, they just have to run their course, okay? And the same thing with the flu. You know, a lot of times they give Tamiflu, but you have to get it within so many days, like within maybe 24 hours of the onset of symptoms, 24 to 48, because, I mean, sometimes it just doesn't do anything, but it just helps. It's supposed to help decrease the severity of the symptoms and decrease the length of the symptoms. Just remember that phenylephrine is it is a decongestant, okay? And we did mention, yeah, I think I told you to go back and read over that at the beginning of the immunological unit. And that is your review in a nutshell. I hope this was helpful. I'm sorry it was so long, but there really wasn't any other way to shorten it. Trying to make sure there's not anything else. And of course, you know, if you have questions, you can always message me. Y'all have a good one.